Welcome to section 42 of the online Falcon Review series. This time we're going to be discussing the other tough nerve of the cranial nerves, and that's the facial nerve. Another important one for you to understand, as there's several questions that can be asked in regards to the facial nerve and its distribution that can be put into clinical problem solving. For instance, a 46-year-old female patient complains of loss of sensation from the left side of her tongue. Upon exam, you find that the loss of general sensation from the anterior part of the tongue, but that taste from the same area is normal and salivation is normal. Which nerve do you suspect has been damaged? The chorda tympani, the lingual proximal to its junction with the chorda tympani, the lingual branch proximal or distal to its junction with the chorda tympani, the greater petrosal, or the glossopharyngeal. Hopefully you'll clue into the fact that this was the proximal portion of the lingual before chorda tympani has joined it. And chorda tympani will be carrying the taste, which will be saved if it comes on after the damage to the nerve. So this would be a deep injury in the infratemporal fossa. And when you think of the cranial nerve 7, it's good to go back to that intercranial, intracranial, and extracranial pattern that we discussed earlier, because this nerve has a complicated course within the cranial vault. The nervus intermedius will contain all of the different components that are not motor, and that includes general sensation, taste, and parasympathetics. They'll all enter with cranial nerve 8 into the internal auditory meatus, where there'll be 3 branches that come off of it while in the bone. 2 will be associated with taste and parasympathetics, and 1 will be associated with a small amount of sensation to the eardrum. The extracranial components will divide up into 3 canals that they'll leave through separately. So it goes into the bone through 1 foramina, and it actually leaves the bone through 3 different foramina. The first is going to be the pterygoid canal, where parasympathetics from the greater petrosal will carry taste to the area and parasympathetics to the area above the corner of the mouth. The petrotympanic fissure will carry out chorda tympani, the one that we just discussed in our previous question, and carry parasympathetics and taste to the area of the paralingual space and taste below the corner of the mouth. And the third one will be the motor branch, which will exit through the stylomastoid foramen, and then it will cleave through the parotid gland to supply the facial muscles. There's going to be several branches of this as it comes extracranially, and the 5 branches to the face will be motor to the muscles of the facial expression. Now, as we look at the intracranial course, you can see how there's several complicated turns associated with the cranial nerve 7. At the internal auditory meatus, it will go in around cranial nerve 8, and then it will take a posterior turn and make a knee-shaped bend called the geniculate bend, or the genu. And from that genu, you'll see the first branch of parasympathetics coming off, and it's picking up some taste to the soft palate in this area as well. That's going to be the greater petrosal nerve. After it turns posteriorly, it's going to run in the horizontal plane for a while before it drops down vertically in the front of the mastoid air cells. And it's here that it's going to give off a motor branch to the stapedius muscle. It's going to give off a parasympathetic branch, the chorda tympani, which will run between the handle of the malleus and the incus near the tympanic membrane. And then there's going to be a branch that comes out through the stylomastoid foramen, because this is where the motor components will get to the muscles of the facial expression. So here's a schematic showing exactly the same kind of idea, trying to do it in a different angle though. You can see how the motor portions will come through the internal auditory meatus, take a dog leg turn posteriorly, and then drop down vertically through the stylomastoid foramen, where it will give off branches like the posterior auricular, the branch to the digastric and stylohyoid muscle, and then the 5 branches of face, which will be the temporal, zygomatic, buccal, marginal, and cervical branches. We're going to have a small motor branch to the stapedius muscle, which is the smallest muscle in the body, and then we'll have the nervus intermedius, which is parasympathetics and taste associated with the geniculate ganglia. Then there's going to be a greater petrosal nerve, which will go through the pterygoid canal. This is the path that it will take to get to the pterygopalatine fossa, which is the mid-face grand central station, where it will distribute to the nasal cavity and the palate. Then we have the chorda tympani branch, which will come through the petrotympanic fissure, get in behind the condyle of the mandible, and jump onto the lingual nerve to get to the submandibular and sublingual glands as they distribute along with V3 and take taste to the anterior two-thirds of the tongue. Here you can see a person that has a facial paralysis, and there's one simple difference between a facial palsy and a Bell's palsy. The difference is known or unknown etiology. If the etiology is known, it's a facial palsy. If it is unknown, it's called a Bell's palsy. What happens is that you can have terminal branches of cranial nerve 7 that might be injured either in the parotid gland or by surgical removal of the parotid. This could be testable items in that you'll see a scenario that is relevant to a parotidectomy. An infant's facial nerve can be injured during forceps delivery, and the mastoid process isn't formed yet in children, therefore it can be a little bit more susceptible if they grab in behind where that mastoid process will start to form. Fry's syndrome is going to be the abnormal response that you get when you have eating, and it causes salivation, and this is typically a response, post-surgical response, because of a parotidectomy or the auriculotemporal nerve being severed during a parotid surgery. We've already discussed the differences between the Bell's palsy and the facial palsy. As far as neuroanatomy, remember back to the fact that if there is sparing of the forehead with facial paralysis, that really means that there is a contralateral damage to the central nervous system. This is looking at a couple of the branches. We'll move quickly through this, but if you need some more time to review the anatomy that's going to be relevant for testing, take a look here and you can see the chorda tympani and the greater petrosal all moving into their relative positions in this particular session. Let's look at the muscles of facial expression. There's several that I think you should be aware of and know. The orbicularis oculi and orbicularis oris are definitely two that you should be familiar with for questions. As far as the frontalis and the zygomaticus muscles, those will not be quite as important, but you will need to understand the depressor anguli oris as well as the labii inferioris. Most of the other muscles, other than the platysma and the occipitofrontalis muscles, are going to be fairly straightforward and only take moments for you to refamiliarize yourself with. Here you can see the peripheral branches of the motor components: temporal, zygomatic, buccal, marginal, mandibular, and cervical, all distributing onto the face. One important thing that you can remember as far as honing your areas of relative positioning down is that if you put your hands over your face and cross the midline, that is going to cover the area where facial muscles are located. If you go out lateral to that and put your hand by the ear and come forward with it, that's going to be the area where the facial nerve distributes. So if you're out toward the ear, be considerate of the possibility of a facial nerve damage, and if you're in towards the face, then you may not be having a facial nerve damage, but you might have a direct facial muscle damage. Now we want to show how this facial nerve cleaves through the substance of the parotid gland. There really is no difference between the different components of the parotid gland, but if you're on the outside of the facial nerve, it's called a superficial component of the gland, and if you're on the inside of that parotid gland, it's considered the internal component. We have the retromandibular vein medial to that, and then finally the superficial temporal medial to that. Notice how you can see the mandible with its inferior alveolar artery nerve running through it.